Good morning. This morning we're going to talk about how to examine the optic disc and some of the features of that. So let's get into it. For this presentation, you'll need some special glasses that have been supplied to you that have red lens over the left eye and blue lens over the right eye. And in addition to that, you have to be capable of binocular stereoscopic vision. Be careful with the glasses. Don't put your finger and thumb on the lenses because that'll smudge them, and you'll be putting them on and off a couple of times during the presentation. You can put them on now if you like, get them all adjusted and ready, and we'll go. We're going to look at the methods to examine the optic disc, starting with binocular indirect ophthalmoscopy, which is familiar to us. It's an excellent method for examining the retina and the details of everything, and is something clinically very useful, but probably the worst method for evaluating the optic disc with reference to glaucoma. The reason for that is that the image is too small and there's not enough stereopsis. It's much better to use a handheld lens. It's also an indirect lens, and combine it with a slit lamp where you can get more magnification even. And to get the greatest magnification, you should use the 60 diopter or the 78 diopter lens rather than the 90 diopter lens. Not only does it give you greater magnification, but it gives you better stereopsis because the axial magnification is the square of the transverse magnification. That means if you are looking at a cube that is 1 centimeter in all directions, and you use a lens to look at it with 2x magnification, it will be on its face 2 centimeters by 2 centimeters, but in the distance going away from you, it will be 4 centimeters, and it will exaggerate that axial dimension. The Ruby lens does exactly the same thing, except that it uses a minus lens instead of a plus lens. And that gives the same magnification as a 55 diopter plus lens would, except that the image is not inverted. And you can look at it with the slit lamp and give it even more magnification as you need. The best way to look at the fundus is with a contact lens, Goldmann fundus contact lens, but it is a little bit clumsier to use. It requires putting goo on the cornea, which may make it difficult to get photographs later on. And so you use that when you really need to have a better view. You can also examine stereo pair photographs, and that's a good way to look at them too. The disadvantage compared to the slit lamp method is that you don't have the slit beam to use, which you can use to profit at the slit lamp in order to move the slit across the disc and so on, and get another way to evaluate its three-dimensionality in addition to the stereopsis. At this time, if you would, please take off the glasses carefully, don't smudge the lens, and we'll use them again in just a minute or two. We may do this a couple of times through the presentation. Now here, without stereopsis, you can see physiologic cups. What one can see is that the nerve fibers come from the different regions of the retina, and they enter an opening in the sclera, where they then proceed out the back of the eye, forming the optic nerve. And there is a nice little sleeve going around the exit canal. It's represented in white here. And what's left over after the nerve fibers occupy a certain portion of the disc is a cup in the center. And the larger the disc is, with the same number of nerve fibers coming in, the larger the cup is in the middle. And that's just normal physiology. That's the normal anatomy of the optic disc. And the size of the cup depends simply on the size of the disc itself. Now, in glaucoma, what happens is that there's a sectoral decrease in the number of nerve fibers. And so while there are a good number of nerve fibers entering down here, up at the top, we can see that there aren't as many nerve fibers. And so therefore, in the top sector of the disc, it's a little bit thinner than it is in the other sectors. And that is the predominant basis for recognizing early glaucomatous cupping. It's recognized by the absence of the amount of tissue here. And the rule is that in a physiologic cup, the inferior sector has the most nerve fibers. Next is the superior sector, but that's violated in this picture. The superior sector is not the place where there's the most abundant nerve fibers. Then comes nasal, and then comes temporal. And that's the rule. Inferior, superior, nasal, temporal, isn't, ISNT. That should be the sequence, and it's violated here because the inferior is not the second most abundant, the superior is not the second most abundant sector. And to go along with that, there are defects in the visual field seen in the inferior sector of the field, corresponding to this retinal region. It's a Goldmann field in use at the time that this was discovered, that was the sign of glaucoma. And but these darkened areas are areas where there is diminished vision. And you can see the difference here, can't you? I mean, here is a disc where there's an abundant amount of tissue in all sectors. And here, there's a good amount in these sectors, but a deficient amount in the superior sector. And it's the second one, inferior, superior, nasal, temporal. So it should be the second most abundant, and it's not. So can you tell the difference between a normal configuration and a glaucomatous configuration? It's almost as simple as that. Well, not quite. We're going to see some places where we have trouble determining whether that's so or not, but that is the difference. To go through and just recheck ourselves on the anatomy, what's happening is that the retina is here, and there's nerve fibers. They're all coming together toward the disc, and so they are thicker in amount at the disc, and it's harder to see. It's harder to see through this to see the disc and the edge of the disc, but that's the area we're going to be wanting to examine. And you can see the choroid is underneath the retina, and then the sclera, which comes and joins the dura mater. And across the nerve, as it exits, and just before it gets its myelin and turns into white tissue instead of gray matter, the lamina cribrosa goes across, and there are holes in it. You know that. I want to point out the flange of scleral tissue that goes around this exit canal. It comes up and in most cases separates the choroid from the disc. And you see that when you look in, you see it as a white stripe around the disc. Here you go. Here you have the disc tissue and so on, and there's the white stripe. And it's an important landmark because all the judgment about the nerve tissue, when it's looked end on like this, is going to be judged from the inside of this ring of white. Here it is in a larger disc where you can see the inside of that. That is the real disc margin, so to speak, is the inside of that white ring. And your judgment about the tissue being present is the diameter or the radius from that point. This demonstrates the isn't rule. Inferior first, superior next, nasal next, and temporal next. And in a larger disc, again, inferior, superior, nasal, and temporal. This is an illustration of the entire field of view, and it is shown only to emphasize that there is a mounding of the tissue in the region of the optic disc and making it more difficult to see the details at the edge of the disc. And we'll see some examples of that. In fact, in this particular one, although you can't quite tell, the pigment epithelium comes in and covers part of the choroid, and we're going to see what that's about. Here, the pigment epithelium is coming along. And when it gets to the end of Bruch's membrane, it makes a turn back and then continues as the neural retina. Here's where the photoreceptors start. And so we have this area of deep pigment just ahead of the disc margin. Here's the scleral flange right there. And when you see it ophthalmoscopically, it's like this bottom photograph. It's around the disc and around, look carefully, here is the white rim around the disc, and the disc tissue starts inside that white rim. Not very pink, it's not very darkly colored in this, its contrast isn't right. But anyway, there's a, an anatomic variation, and that's the point of this. There are some humongous anatomic variations with a tilted disc. And here, if you look down with an ophthalmoscope, you will see the sclera, and you'll see the choroid, and then you'll begin to see some of the layers of the retina, and there'll be a rim of anomalous tissue that you see surrounding the disc. Okay, now is the time to put your glasses back on with the red lens over the left eye. I see lens is misspelled. Sorry about that. Put the red one over the left eye, and we're ready to go. And here you can see a physiologic cup in stereo. And prominently, you can see the rim around the tissue, and you can see the disc tissue itself around the circumference. And as always, the inferior one is larger than the superior one, which is larger in turn than the nasal one. And the temporal one here, it's a little slanted, and so you don't, but it's not as abundant as nasally. And so there we go. And here's, again, another normal disc. We get tired of that after a while. But here, we notice something different. Superiorly, the tissue that's here is a little bit sparse, not quite as much as there is down below, or nasally, or temporally. There's thinning of the rim of tissue here, remembering to count only from the inside of the scleral rim. And right here, there's just not very much compared to inferiorly down here. And that's a sign of early clinical. That's it. Is that you can see that there's more tissue above and below than in the right side after it has progressed. Same disc seen some months later or years even. And now you can see that there's not as much tissue. The tissue has disappeared from down below, and it's excavated. And up above, it's excavated in comparison to the before picture. It's subtle, but it helps to look at the other eye and see that they're not the same. Now, sometimes there's a tilted exit of the optic nerve. So this is a time domain OCT, not very modern. But the nerve fiber layer is coming and then leaving the eye in an oblique fashion. And from the other side, from below, it comes and it leaves the eye obliquely. And when we look at that ophthalmoscopically, we can see that the nerve goes around, but that from below, the nerve goes straight in. And it's actually a little hard to tell where the scleral lip is. Makes it very difficult to evaluate this sector of the disc. But the thing is that when nerve fibers disappear, looking at the OCT diagram from here, what happens is that the side of the cup moves outward. When nerve fibers disappear from this side or the bottom, actually what happens is that the cup goes backward more than it expands outward. And so to judge this disc, we have to be thinking in our mind, not what this direction, but in the direction toward you and away from you as to whether or not that is getting thinner. And that's what makes it difficult to evaluate a disc where the exit is oblique. This is the other eye, same patient. Here's another, this is a non-glaucomatous disc that has a tilt. And you see the vessels tending to not go through the center, but going instead to the bending around and going beneath our field of view, whereas the fibers that are coming here are coming in and just going in a flat plane and exiting also to the upper left. And it's judging the thinness of this area is difficult because the sitting goes away from you. Fortunately, what happens is that when doing so, it becomes pale in addition to excavating. And then you can tell that sometimes and see kind of a pale extension of the cup in a vertical direction, and that's a key marker. Oh, sometimes it's just almost hopeless. There is so much sloping that the vessels going around there, and here, oh, the nerve tissue is kind of a broad thing here, and how could you ever tell that it's moving away from you and backwards? Well, the only clue is going to be pallor. You can see that there is some loss of some coloration in the tissue in the lower temporal quadrant, and the actual bottom of the cup is way over here. And so maybe there's the same amount of tissue. Very difficult to judge. So the beginning of tissue loss is at the inferior portion of the optic nerve in this particular example, and the inferior sector has a certain width, and the cup becomes taller than it is wide. And that sometimes is a way to kind of get your first clue. The evaluation should really be of the thickness of the rim, but you can get your first clue by noticing that the cup is vertically oval And that would be true here. Here there's thinning down in the lower temporal quadrant. And so the bottom of the cup actually looks oval and in a vertical direction. If you lift up your glasses momentarily, you can see the shape of the white cup in monovision. And it is taller than it is wide. Okay, put the glasses back down. But the stereopsis does enhance your ability to evaluate that there's kind of a excavation down here inferiorly. It's like there's a nest that's been created for something that's shaped like a football rather than a square spherical ball. Another instance of early glaucoma. It's kind of thin up here on the upper temporal side. Compared to elsewhere. So it's localized cupping, usually above, but sometimes upper temporal or lower temporal, and as we'll see sometimes elsewhere. But this disc did go on and progress, and so now it's much more evident that the poles of the disc superiorly and inferiorly are excavated more than the other poles of the disc. Another disc where it's thinner up above than it is below. And it progressed over 96 months. Here's one where the excavation is localized more nasally than in other sectors. So, yeah, I guess the isn't rule is violated because the temporal rim is smaller than the nasal rim, rather, is smaller than the temporal rim. But the excavation, the localized loss is placed nasally, and that's a variation. So the real rule is localized loss of nerve fibers, usually superiorly and inferiorly, but can be any sector, and that's glaucoma. So this one and the field loss would be different. So here's a case of early disturbance nasally. So what do you think about this disc? Give you a minute or so to look at it. Think there's any problem here? Well, pretty good, healthy rim. Well, when you look at it in stereopsis, you come to appreciate that there is really an excavation down here inferiorly. And that's where the stereopsis comes in. It wasn't so obvious when you're looking at it in the monocular view, which is the one on the left. The stereoscopic view does help you to recognize this, and that's the importance of using not using the direct ophthalmoscope, for example, but using a binocular view. This particular case, you can come to believe if you realize from your records that there was a splinter hemorrhage down inferiorly 5 years earlier than the photograph shown. And if we compare it to the other eye and realize that they're different. All right, what do you think about this one? You got it? Okay, well, this is an example of a vertical extension of a white stripe away from in the bottom of the disc. And actually the excavation goes down all the way to the bottom. And it's more that it appears white than it does excavated because it's a sloped disc. You see the vessels are leaving way over here, and this disc is sloped. And because it's sloped, you're looking down on the face of the tissue that's exiting the eye, and you don't get so much a stereoscopic clue but the power tells you, and now that you look at it, you can see the rim, you see ending and just disappearing down there. And along with that, field loss. So let's go on to another instance here. Oh, what do we have here? We have a disk where we can see the scleral rim and follow it around, and it goes, I guess, around here, huh? Going here. I guess that's it. And then over here on the other side of that rim, we see reduplicated pigment epithelium, which we're used to seeing here. We see some right up here at that top of the disc. So there we are. And the rim is a little bit thick, the scleral rim. But what is this pigmented tissue inside the rim? That's a strange thing. And what it is it's uveal tissue that is coming underneath this distorted disc, underneath the retina, over the scleral rim, and under the nerve fibers that are exiting through this tilted disc. And it shows up as a pigmented crescent described by Bruce Shields. It's called a Shields crescent. And it's different from the pigment epithelium crescent as seen here. And it's underneath the nerve fibers. It's just an anatomic variant. But remember that we have to evaluate the rim tissue from the interior of the scleral lip into here, not from out here and not from inside the gray crescent either. The gray crescent is actually part of the innards of the disc. And this is a tilted disc, and so it's hard. This is the flat side, and this is the humped up side. And so it's difficult to evaluate. You need to recognize this anomaly. This is another example of the same thing. And yet another. Sometimes things are so messed up that you really just can't quite tell what's going on. I mean, here is the scleral rim, obviously, I guess, obvious. And then a gray crescent inside of it. Oh, and here, this would be the end of the pigment epithelium, doubled over. We're used to seeing that. There's a sample of it up here too. And then what is this line? I don't know. This particular photo has been passed around among some glaucoma specialists, and everyone is kind of puzzled at that. Maybe that's where the photoreceptors end or something like that. But anyway, sometimes you can't quite evaluate things. But with regard to glaucoma, we can, again, look at the rim tissue inside the scleral lip. And in this case, you have to recognize that the scleral lip is going out to here in order to evaluate this sector. And it actually doesn't look bad. And if you need to go and do an OCT or do a visual field and see that actually this disc is not affected by glaucoma, and not take it that it's excavated to the rim here, falsely assuming that this is the rim, when in fact the rim is out here. And another instance, it's difficult to judge, isn't it? Now, sometimes there's an anomaly all the way around the disc. And what's happened here is that the pigment epithelium has ended before reaching the disc. And you can see right down onto the choroid, which is hidden by the pigment epithelium elsewhere. But here you can look right down on the choroid. And there you see the dense scleral ring is obvious. And this has sometimes been thought to be what's called a glaucomatous halo. And it's called peripapillary atrophy because it's assumed that it was previously present and it atrophied away. It disappeared. That is probably false. People are probably born with an anomaly like this. And the thing is, though, that they are more sensitive to pressure and the effects of pressure because the choroid doesn't nourish the nerve fibers that are going across this space where there's no pigment epithelium protecting it from the choroid. And as it goes across the space, it's going to disappear and be damaged. And so many discs are completely excavated and have this halo, and it's assumed that the halo resulted from the glaucoma. And while it is true that people that have some disturbance of the pigment epithelium around the disc, it can enlarge over time in a glaucomatous patient, sometimes in normal patients. It's probably not true that it all resulted from glaucomatous damage. There are plenty of examples of people that have halos. But with the exposure to the choroid, the nerve fibers are susceptible to damage. And so they easily can get glaucoma, even normal tension glaucoma, and look like that. Sometimes it's not in a ring, but it's just as a sector. Here you can clearly see the end of the pigment epithelium, and it's doubled over. And that's not the kind of thing that would happen from atrophy. So this is an area of there's the scleral rim. There's an area of choroid that's been bared, and it's a tilted disc. And this is actually called an inferior conus. Frequent that this sector of the disc becomes excavated because the nerve fibers are subject to disturbance when it goes over the bare choroid, or at least that's my idea of it. Okay, in the time that we have left, I think I'll just run through a number of examples. It might be a little bit repetitive, and we'll just go as fast as we can here. Here's an example of one that's clearly glaucomatous. There's the glaucomatous halo that we talked about. There's splinter hemorrhage on the nasal side of the disc. The cup goes all the way down to the rim here at the bottom and all the way up to the top, and you wouldn't have any trouble recognizing that as being glaucomatous. This is another one where there's clearly almost a notch. And by the way, this type is oftentimes associated with dysregulation, is to have very localized loss, almost like a pit that goes. Here's one that's not quite so prominent, but similar in that it goes down to the bottom and right over here, almost to the rim. See, the scleral rim is where? Right here. And it comes down there. And so that's close to the previous one in terms of its general shape. The white spot is sort of like a teardrop. Oh, here's one where, again, there's a deficiency of rim tissue right up to the scleral rim. See, and you see the scleral rim. This is not the edge of the disc up here, but right there where you see it. And clearly there's a verticality to that. Let's see. Now we have here, side by side, two examples. I think you could recognize this one quite easily as being normal. And this one quite easily being similar, but having an excavation down here, even without your stereo glasses, which, by the way, you don't need for these. These are not in stereo. So I think now you can tell the difference between glaucoma and normal. And I think here you see glaucoma on the left and normal on the right. It's almost, you just take a quick look and all of a sudden they just don't look the same. And similarly here, that look like a glaucomatous disc to you? Maybe before today it might have, because the cup disc ratio is so large and people take that to mean it must be glaucoma, but this is clearly not. You can see the abundant tissue inferiorly and superiorly as well. And then nasally and then temporally, the isn't rule serves you well right there. So does anybody have any questions? If there are no questions, we'll just take a rest for a while. Have a good lunch. Well, that's enough for today, I guess. There is a lot more that could be talked about, but let's end here and go on to see whether or not there are any questions you have.